Hi, I'm Dr. Neel Shah, and welcome to the DBT Podcast. All right, welcome to the DBT Podcast. I'm Dr. Neel Shah. I'm very lucky to have one of my favorite family members of all time, the GOAT, Dr. Sheil Shah, a radiologist. Dr. Shah, can you introduce yourself maybe?
How's it going, everyone? Neel, thanks for having me. Yes, I am, as you said, diagnostic radiologist. I live here in D.C., but I was born and raised in the Detroit suburbs, so I'm a big Lions fan, as Neel knows. But thanks for having me. And
Yeah. Did you watch that Pistons beatdown of the Bulls yesterday with their second team? I mean,
yes, sir. I love it. It's looking good so far.
Yeah. We both got the Lions and Pistons are just racking up wins. So hopefully we'll win this weekend in Philly. But I think it's an amazing thing that you're a radiologist, and my understanding of your job is like basically you help me because obviously patients come to me and they're like, hey, the most common I get consults for this still. They're getting a picture. You guys are doing your best to read that picture and understand, and you have to put things that you're seeing that something could be. So I want to start by just saying, 50 years ago, we didn't have CTs and MRIs. Is that right?
That's right. The first CT scan, I believe, was performed in 1971. So
It's not that old, man.
not that
It's
old.
a little bit older than me. I know you're way younger than me, but not that old. So the first CT was in 1971. Wow. Okay.
And then MRI was soon to follow. I believe the first MRI was in the late 70s and started becoming more of a thing in the early 80s. So, yeah, it's
Wow.
relatively new technology.
Wow. I mean, I think it's an amazing thing. Prior to that, a lot of my patients, and I tell them this, they think I can look at them and know what's going on the inside of the human body. And I tell them that's just not true. We don't, that's why we do mammograms, and all this imaging, because you and I can feel fine, but we don't know what's going on the inside of our bodies. You can have stuff happening on the inside and not know about it, including things like vascular malformations or all sorts of stuff, including cancer, of course. I mean, is that something that you agree with?
Absolutely. There's just so much going on inside of our bodies that we may have no idea about. And, that's the power of imaging. And, it's, it's very humbling to see, what in my job, it's basically, as you mentioned, it's my job to look at images, to diagnose, analyze, interpret what I think is going on. So, you kind of get a unique perspective on the population when it's your job to look at people on the insides and see what they're dealing with day in and day out. So, yeah, radiology has really come a long way. Like, as you said, like with the technology available now, 50 some years ago, when you walked into a radiology department, it looked much, much different. Back then,
Back then, you had people with really good eyes. They had 20/20 vision, and they would just look at you, and that would be radiology. Is that what you're saying?
Pretty much. I looked at a CT image from 1985, and it was like as if you smeared Vaseline and jelly all over the image. Like how were people? I mean,
Even looking at this.
Yeah. So it's come a long way. And
so how did someone discover that you could use? Let's just start with MRI magnets to look at the human body. It just still blows. I've had an MRI. It blows my mind when I think some person discovered you could use magnets to look. I still don't quite understand it. And there's a lot of things I just don't understand. It's one of the points of doing this podcast. I don't know if you can explain that a little bit.
Yeah, so very, very smart people develop this technology, that's for sure. And it's all about, being put in a magnetic field and how like your body composition and atoms react to that magnetic field. And that's a very, very layman's way of describing it. It's very kind of advanced technology, But what's really neat about it is it doesn't expose the patient or anyone getting MRI to radiation, which is really cool. So
Yeah, I tell every patient there's really no downside to getting an MRI, and maybe we can just kind of jump right into it. There are companies now that we don't need to name the companies, but they are, and you can go anywhere really and pay for a full body MRI. And I'm just curious, as a radiologist, your thoughts on that. And look, we're all, especially once you hit 40, 50 years old, we all have friends that something's happened to them, and I always wonder if they would have had an MRI, would we have caught something a little bit earlier? Could we have done something a little bit earlier, considering the fact that things don't just usually happen? They've been brewing for a little while. Like Peter Attia was on 60 Minutes, and he said, like, "Hey, you know what? I send my patients for these MRIs." So I'm curious, as a radiologist, what your thoughts are on that.
yeah, so I think it's a new idea and technology to do like a full body MR screening. I think in the last like 5 to 10 years, it's kind of come into public focus. And right now, I think just as a general statement with that is there is a lot of promise. I think it has its benefits. But is it something that I would just recommend to anyone on the street? Not necessarily at this point in time. I think
Why not?
there's just a lot of research that needs to be done on that right now. So basically, all the big studies coming out right now. And I was just looking at one from Europe. It was a big like meta analysis looking at like 9,000 some patients that that got these full body MR screening studies. It diagnosed cancer in about 1 to maybe maximum of 2% of patients.
Okay.
So I think they're obviously like that's the goal. You want to be able to detect a cancer at an early stage, something that you're unaware of. That's obviously the goal. But there are some downsides to
Sure.
these kinds of full body MRs. Mainly, there are a lot of incidental findings that we can pick up on MRI, on really any imaging modality that are benign findings. But these are things that need to be further worked up and tested. And so ideally, yes, if you are in that 1% of patients that we find a cancer, a kidney cancer, or bladder cancer, or ovarian, pancreatic cancer in its early stage, like that's great. That's the goal of the test. But for the vast majority of patients, um, you're gonna essentially find nothing, which is also great. The other more plausible scenario is we find a lot of benign incidentalomas, as
And
we
then you got to have more tests, right, for
and then
that?
a lot of further workup, further tests as a follow up to that. So, a common example of any doctor that's ordered any kind of CT or imaging study, we find these little tiny pancreatic cystic lesions that are 99.9% of the time benign, but we do need to follow it over the years just on the off case, very small percentage chance that it could turn into a cancer down the line. Uh,
Right. So then you're getting follow-up imaging for the rest of your life. Do you really need it or not? I
correct.
mean, I think that's the question, right? And then obviously cost does come into play. I mean, I think it's what they say: a quarter of Americans live paycheck to paycheck. So it's certainly something where I'm hoping the cost will come down too, because I think that definitely goes into play. Would you agree with that? Or
Absolutely. Yeah. Right now, it's a pretty penny. It's insurance doesn't cover it. Depending on the center you go to, like you're looking at, 2 to 3 grand for a full body MR scan. So, not exactly a cheap study. So, you know, obviously that's not feasible for a lot of people. But if you are in that boat where you are thinking about it, um, I would say it can be of a very powerful benefit to people that have strong family history of cancer. Your parents, your siblings, like have some form of cancer. You're for whatever reason have an increased chance of developing it. I think those are the types of patients where full body MR scan can be considered for sure. other patients that have certain genetic factors, genetic predisposition syndromes that can predispose them to developing cancer in the future. I think for the certain types of patients, um, it can be very useful for sure.
Yeah, I mean, it's just an amazing thing. And, I think you mentioned the how the pictures have changed. You know, MRI, like what size can you even show? This is gonna be on YouTube. Like, is there a size? Like, what size cuts are they doing that you can see? Like, when I tell patients and we talk about nodules or something, which maybe we'll get into, I describe it as like this is a centimeter, this is a millimeter. Is that how small we're seeing things on MRI?
Oh yeah, absolutely. Yeah, you can, anywhere from 1 millimeter, 5 millimeter, 3 millimeter cuts. So yeah, you can detect very tiny pathology. Say for example, in the adrenal gland, we see these small adrenal nodules all the time that are sometimes 2 millimeters. So yes, you can detect very very tiny pathology on MRI and CT scans. So yeah, the technology is really advanced, and we can kind of get into as a side like all the other modalities that uh, that you can get as imaging tests done when you go to the hospital or outpatient centers. Um, but yeah, it's come a long way. You can see a lot on the inside nowadays.
I'm just curious if the cost comes down, will it become? Because I always wonder about, okay, if you're catching like the cost of things, like it's expensive to see an oncologist and get cancer drugs and all that. If we can avoid, I always joke that like my point of the podcast is to have less patients. So can we avoid that by someone catching cancer early and getting it detected early and having it removed with whether it's imaging. We had a pathologist on about blood tests. Is the cost of those going to come down? And then we'll all be getting MRI starting at 50, let's just say. I'm curious what your thoughts are on that.
Yeah, I think it's certainly, I think we certainly could get to a point where, it'd be more cost effective for people to get these things done. And that's the general trend, for sure with technology advancement. I think we could certainly get to a point in the near future where it just becomes like simply more cost effective for people. So I don't think we're too far away from that future, but I think at this point, there are also other screening modalities that you can do, more standard screening, cancer screening
Sure.
modalities that you can do to detect different types of cancers. So yeah, I think again, it's the early days.
I mean, 1970s, and now we're only 50, 50 years. How far have we come? It's pretty crazy. And I think, some of these, I think that imaging is so good that's going to tell us about other diseases too, not just cancer, but maybe the amount of muscle mass or visceral fat and all that. And I think that will lead to some, everyone's focused right now on longevity, and essentially that means not getting diseases, right? Not getting dementia, heart disease, stroke, cancer, all these types of things. So it's a crazy, crazy thing to think about for the last 50 years, how things have advanced. So speaking of that, I always joke around with our radiologist at our local centers is I tell them, next year I might not see you because AI will just take over. But I don't really believe that because I think maybe AI will be a good tool to screen out, in my opinion, like all the normal, stuff. And then it's like a good way to like have you guys be more efficient in terms of just reading the stuff that really needs to be looked at. I don't know what your thoughts are on that type of technology. Is that all coming? Like what's changing for
Oh
that?
yeah, yeah, oh yeah, absolutely. So it's a big, almost daily discussion in my world of, hey, is AI gonna take my job? And who knows what the future holds? Of course, I think down the line, generations from now, at least we're 2 or 3 generations
Yeah.
removed. Who knows? I could
Yeah.
be wrong,
Well,
but
listen, Sheil, if it takes my job, I'm just going to move in with you. Is that cool? Or
hey,
all
I'm
right.
probably first on the chopping block. Like, let's be honest. So, I might have to move in with you, or maybe
I love it, man.
Office.
I think it'd be a blast if you moved in with me, although I don't think our wives would like it very much.
We'd have a good time. Have a good time.
I think we'd have too much fun. But anyway,
Well,
uh,
AI software is, we already use it in our normal daily practice.
oh, I
So
didn't know that. Maybe you can talk about that a little bit.
sure. So a big AI platform that a lot of radiology departments use now across the country is called AI Doc. So this is a platform that helps us detect critical findings. So say 10 CT scans, a stack of 10 CT scans that we have all at once. We can't look at all of them all at once. We have to go one at a time. This AI platform helps us pre-read, so to speak, pre-scan the images. And if there is a critical finding that the AI platform detects, it alerts us to it and says, hey, Sheil, you need to look at these images next or look at them now because we think there's a critical finding. So critical finding meaning a brain bleed, something acutely life-threatening, clot in your lungs, pulmonary embolism, um, stomach perforation or a bowel perforation, something that needs like emergent surgery. So it can really help in those kinds of like critical scenarios where you need to be able to look at the images, diagnose it quickly, so that the patient can get treated quickly and appropriately in a time sensitive fashion. So that's one area that I think it's really helped. There are other like AI software platforms that we use. As you've experienced, some of these radiology reports can be very long and extensive. There's a lot of findings. Um, and at the very end, we make what is called an impression, which is kind of like the main takeaways of what we think is going on. So there are AI platforms now that we use that can help us draft an impression. So that way we can make reports faster and in turn get reports to their doctors and patients quicker so that, the bottom line is, the whole goal is to, improve patient care.
Yeah, I mean, I'm glad you said that because I feel like, obviously there's a lot of litigation in the country, and I think another point of this podcast is for people to meet real doctors. They don't get to meet you all the time. That everyone's trying their best to help people. It's not like I know you. I've known you my whole life. Like, and I had my other cousin on. Like, we're all trying to do our best to help people, and obviously, including myself, we make mistakes, and so hopefully this technology will help cut down on that. Obviously they're all unintentional, but like, if we can improve that, I think I'm all for it. Try and cut down on what we may miss, or obviously there's so many gray areas. People think it's definitive on what we do, and nothing I do is definitive, right? I mean, if you guys have something that's a nodule, I mean, people ask me about it, and I'm like, yeah, it could be cancer. Anything can be cancer, but
Right.
like you
Right.
wouldn't know unless it doesn't look like cancer. Statistically, it's unlikely to be cancer, but unless you cut that thing out that you're seeing and you analyze it under a microscope, you really don't know. Is that right?
Absolutely. Absolutely. So, I think, yeah, there's a lot of gray area in what I do too. So that's kind of a misconception of what radiology is too. That people kind of view it as like a lab result or positive or negative, and a lot of the times what we're seeing lands in the gray area. And so there are certain instances where say you think you broke your hand and you get an X-ray and the bone is either broken or it's not, like positive or negative. But then with other disease processes that go on in your body. If you're looking at something that could be cancer or not, is it benign or is it not benign? There's a lot in the gray area, and so we just do our best to try to diagnose these things as best we can.
Yeah, I mean, it's scary to be, when you get older. Like I liked when I was younger, and you and I. Well, let's talk about this first. Actually, I just want to. My brother's probably going to listen to this podcast. I just want to make it clear, first of all, that you and my brother are 6 feet or taller. Is that correct?
That's actually not entirely correct. I'm 5'11", so I'm
Okay.
right there. But yeah,
Okay. And I just want to make it clear, when we were growing up, you guys still tower over me. I think you've towered over me since you were 13 or 14, me being 5'6". And I just want to make it clear, though, on a basketball court, one-on-one, that who would be the winner one-on-one versus me and my over 6 foot brother, or me and you? Who do you think growing up, who would win that battle? I mean, realistically, we've had one-on-one games. I just want to hear you say it on the podcast publicly, for my glory. I don't play basketball anymore. I'm too old, but for the glory.
I'm pretty sure your brother has never beaten me one on one. I mean, he might claim otherwise, but I think we went 50-50. I might have
50-50.
I might have
Tell
the
the truth, man. We're trying to tell the truth on this podcast, man.
you can, this is your podcast, so I'll allow a little bit of revisionist history. That's okay. What can I do with that?
Yeah.
But
No, that's fine. That's fine.
That's all I'll say on that.
I mean, they used to call me the Indian Isaiah Thomas. I don't know if you remember that, but that was my nickname. I don't know if you
were the
remember.
floor general.
The floor general. Yeah. He had a lot of turnovers, but this team is looking really good, Sheil. I think you and I may be able to go to a playoff game this year in Detroit. Hopefully you can make it. I think the Pistons are going to be pretty good this year.
Yeah, no, absolutely. We should make that happen.
And the kids,
Yeah, no, absolutely. We'll definitely do that. I'm very, very enthused with what I'm seeing with the Pistons so far. So
I mean, it's been amazing. And the Lions, we got a big game in Philadelphia. I mean, everyone's talking about Philadelphia, and like Dan Campbell was on last week, and he was saying when he was a player, they would like dump tobacco spit on him and all that. And I just want to make it clear. In Detroit, we may talk tough, but we're not doing any of those things, right? Sheil, like our fans, we just support our team. We don't need to like go to that level of what Philadelphia does,
We're very respectful people. So, as I mentioned, I live in DC, right? And the Lions played the Commanders last Sunday. So we all went. And, I got to say, so first of all, Detroit Lions fans, we're happy right now.
We show out.
We're enjoying this 3-year ride, and we showed out. Like that entire lower bowl, at least 50% of the lower bowl was all Honolulu blue. And, everyone was having a good time, including our president. Our president made it to the game.
That's right. That's right.
I mean, how can you miss the Jared Goff, Amon-Ra show? I mean, he didn't want to miss it either. So.
Yeah. It's a fantastic team and fantastic community in Michigan that I feel like very lucky we got to grow up there. I think both you and I, if circumstances would have worked out for us, I think we both would still be back there. I think there was part of us that wanted to be back there, but at least we can cheer on our childhood sports teams, But yeah, so I guess, okay, so now I want to kind of talk about CT scans. And so what does CT stand for? Explain to me, what that, and how is it different from an MRI? I don't quite understand all that.
Yeah, sure. So these radiology studies like X-ray and CT, they expose a low level of radiation, whereas ultrasound and MRI don't expose patients to radiation at all. So just going back, actually, can I take a second to explain radiation? Maybe
that'd be great
for listeners.
Because everyone's always worried about getting radiation on a CT scan, They're always worried about it. Like every patient's like, hey, am I going to get too much radiation? I mean, I order probably 3 or 4 CT scans every day. So
radiation in general, the way to think about it is it's basically a strong form of energy that travels through the air. You can't see it in the form of a wave or a particle. And so if we all remember that graphic that maybe we were taught in grade school, but the whole electromagnetic spectrum. So on the very left hand of the spectrum, you have your radio waves and your microwaves. And then in the middle of the spectrum, you have sunlight or visible light, which is what we see. And then towards the other end of the spectrum, you've got X-rays and gamma rays. So X-rays that's the type of energy or radiation that we use for medical imaging. So the 4 main common modalities that we use in radiology departments are X-rays, the normal standard X-rays, like we're talking about with broken hand. You can get a shot of your hand or any part of your body to look at bone. CT, which is which stands for computed tomography, which also uses X-rays, but it's just several X-rays. You lay down in a tube, it spins around you. It's fancy technology, basically shines several X-rays all at once in different angles, and that produces this image that we see in cross section. And so that's one of the main kind of workhorses of radiology departments nowadays. And then the other two, ultrasound and MRI, these are modalities, like I said, that don't offer or don't expose patients to radiation at all and are used for different indications. And so CT scans, it's very, very powerful, as you mentioned. Like in your world, you order a lot of CT scans on patients with cancer to see, if their cancer is doing better or worse or the same. And so, yeah, I get that question all the time.
So is there, I guess my question is, like, people are a little bit worried about the amount of radiation they're getting with the CT, as you mentioned. Is there a danger for them getting too many CT scans? It's a common question that I get.
Yeah, so I think so. Really, nobody knows the answer to that question definitively. What we do know is, for example, a CT scan of the abdomen and pelvis. Um, let me take a step back. So basically, all of us are exposed to radiation on a daily basis, like just by existing on this planet, right? So the average.
So you and I are exposed to radiation right now, basically. Because, I
Correct.
mean, everyone has buzzwords that I think people get afraid of.
Yes.
So, like, radiation is one of those things. Radiation, bad. But, like, what people don't understand is that we all are exposed to radiation every day. Is that
Correct.
is that correct?
That is correct. Just by existing where you are on this planet, we are all exposed to approximately 3 millisieverts of radiation per year. And so, what that means is millisievert is the unit of radiation exposure that we can quantify. And so, just by sitting here, not even leaving your house, like you are exposed to a low level of radiation year round in the amount of about 3 millisieverts. So an X-ray, for example, has about zero point 0.1 millisieverts. So it's very, very low dose. Um, when you take a flight, when you take a cross country flight, you're also exposed to a certain low level of radiation, like zero point 0.5 millisieverts.
Okay.
So CT scan, yes, it gives you a little bit higher of a dose, so anywhere between 2 and 10 millisieverts of radiation. Um, but it's still relatively low. And
What level is, like, too high where there could be a potential risk to your health?
yeah, so all at once, the number quoted in research studies out there, different epidemiologic studies, are about 100 millisieverts.
Oh,
So that's like the lowest level dose all at one time.
yeah.
You can
Which you're
receive.
never gonna get. I mean, not even. Yeah.
Correct. And then at much higher levels, like say 500 millisieverts or 1,000 millisieverts, like these are like the natural kind of disaster scenarios like Chernobyl and, nuclear plant um, accidents where, people are exposed in that community to very,
Mhm.
very high levels of radiation. And
Yeah.
that's where at those doses, that can cause problems.
Yeah.
And so with standard radiology studies, X-rays, CTs, they are relatively low. And, I think it becomes more of a question in patients that need constant, frequent CT scans, like say once a month, every other month for whatever reason. That's when cumulative dose can become a question. Um, but I think there are alternatives to that too. Like you can consider an MRI as opposed to a CT then. Ultrasounds for different, you know, for different conditions that you may have. So there are alternatives, but in general, I think the takeaway point should be like these are relatively low radiation levels, um, and usually, in the vast
So
majority.
what you're saying is, as a radiologist, as an expert at what you do, you'd feel very comfortable getting an MRI or CT and not really be concerned about that part of it.
Absolutely.
Not MRI, but CT even.
CT, yeah.
Yeah, yeah,
Yeah, and just overall, I think the benefit of being able to, get a CT scan and being able to diagnose your condition or whatever you have um, outweighs the
yeah. Or make sure
stressful.
you don't have something, right? I mean, a
Right,
lot of times I look at risk benefit ratios for everything, and you know, I think you might be concerned you have cancer, for example, and you get a test and it confirms that you don't. You
right,
know, so it's kind of nice to be able to know that.
right.
Especially as we know that your risk for getting things as we get older gets a little bit higher. So, but yeah, I mean, I think it's just to me, it's still, maybe I'm just geeking out, but like 50 years is not that long, and now we have we're able to just really look inside at such a level of detail in the human body and make sure that we're not having things. Now, as you said earlier, there are things that are probably benign that you can't be sure. And I think you taught me the most common things are like cysts, nodules, uh, scarring, inflammation. You see a lot of that in the human body, right? Like as you get older.
Absolutely, absolutely. Yeah, especially as we approach our fourth, fifth, sixth decade of life. Very, very common to see, little pancreatic cysts, renal cysts, adrenal nodules, scar tissue like gallbladder polyps, gallstones, pulmonary nodules in the chest. Most of the time, vast majority of the time, these things are benign and nothing to worry about, but it does require some surveillance.
Yeah, I had some imaging done. They said I had the heart of a lion and my legs pump like pistons. So I don't know what that means, but
Accurate,
uh,
accurate diagnosis.
oh man. Well, Sheil, is there anything else you wanted to talk about today to the general public in regards to radiology?
No, I think that's it. I think we covered a variety of topics.
Yeah, I mean, I think you'd encourage, like I have on this podcast, screening. I think the modalities of screening. I think for me, there's three that I can think of. Please add on if I'm missing something. But obviously, getting a mammogram. If you're a smoker, you have a smoking history. Getting a screening CT scan. I think they can do that with. They call it low dose. I think low radiation. Is that right?
That's correct. Yeah, that's
Okay. And by the way, you don't need any dye to detect nodules, right? When you're looking at the lung parenchyma.
correct.
Okay. Yeah, I talked to the radiologist. Just want to confirm that hasn't changed. And then, and by the way, why do some people get dye for their scans?
So dye can really help evaluate organs, mainly more really in any part of your body, but it just helps us detect. Um, what the easiest way to say it is, it basically lights up all your organs, and so you can see finer details better. And so
Okay.
for certain areas in the body, it does help. Um, but for example, in the lungs, you don't necessarily need the contrast to evaluate the actual
Is
lung.
is it because the lungs are, when you look on a scan, they're just black because it's air? Is that why?
Right. They're air-filled structures,
Okay.
yes. And so
Okay. That
whereas,
makes sense to me.
say, in the abdomen, evaluating your liver, it's a
Yeah.
very, like, vascular, organ, and
Uh-huh.
so in order to evaluate the liver, fully, the contrast dye is very helpful in, um, seeing the fine details of the liver, for example.
And as you know, 50 years ago, if they saw something on a picture, they'd have to cut you open and do a biopsy. But nowadays, you don't need any surgery. They can use a needle to know exactly where to go if they see something that's concerning. Is that right?
Yeah, exactly. So that's usually something that interventional radiologists do. It's called a biopsy. They do a very targeted biopsy that's image guided. So they use imaging tools to help them locate exactly where to go. So, for example, if you have something in your liver that needs to be biopsied, they can either use an ultrasound or a CT scanner to help guide the needle to exactly where it needs to go. They can sample it. Um, remove it, uh, give it to the pathologist. They can run a whole host of tests on it and tell you what it is. And all you have as a patient is a tiny little needle stick that most of the time doesn't require a stitch. It's just a little band aid. So It's pretty easy and
I
non-invasive.
mean, it's still amazing from where we come from, which is cutting someone open. So it's just like a crazy, crazy thing to think about. But I just want to thank you again. You're the first family. Well, I shouldn't say that. Second family member on the podcast. First medical doctor to be on the podcast. So I just want to thank you for all you do. I know you work hard to make sure that the patients are taken care of, and thanks again for being on the podcast, and hopefully we'll be able to watch a lot more Lions and Pistons victories together.
That's the plan. Neel, thanks for having me. Appreciate you.